and obviously we are nowhere. No, we are not even on that path. Forget about going towards that. We are not doing it individually. And at this course, we always discuss who is, who are we accountable to eventually? Upar wala. What are you going to tell him there? Look, I wasn't trained, but I took that polyp out because I had seen Paul do it, so I knew how he was putting the snare and just snapping it. And I didn't think it was difficult. How will you justify it? And that's what you have to. See, we have no accountability systems here like they have, but we do have an accountability system that we are all answerable to, and the patient doesn't know. So you are going to be in that. And so always remember when you're dealing with your patient that we as doctors are accountable to Allah. Period. सवाल बहुत सख्त होगा जितना हमें अजर मिल रहा है कि मैं हमेशा अपने ट्रेनिंग से कभी होती है मैं कहता हूँ हमारा प्रोफेशन डबल एजेड स्वॉर्ड है आप अपने गुनाह भी काट सकते हैं और अपने आप को भी काट सकते हैं मर्जी आपकी ठीक है देयर इज़ नो हार्म डूइंग समथिंग डिफिकल्ट इफ़ यू हैव समबडी स्टैंडिंग विद यू for surgical skills if somebody has never done an appendix and decides to do an appendix by himself because he's read a surgical textbook and saw some surgeon do it, it's not fair, is it? You don't need accountability, you need care. But if you stand with Professor Sajda here and she makes you do one, there is no problem. Even if some complication occurs, it's fine because you've got some supervision. Similarly for our course, one of the messages we want you to take is that you need to know your limitations. You are a good doctor, good surgeon, good physician, good human if you know your limitations. If you don't, you're a dangerous man, especially with a tool, whether it's scalpel, whether it's laparoscope, whether it's a colonoscope, whether it's a gastroscope. So I think that's important. How do we suggest you do it? You make your own logbook. The points that are there and they have been given to you on your USB na? USB में ये presentation है जो उनके parameters the parameters that Paul has just mentioned you put them down and start assessing yourself not an issue how much sedation you gave you reached cecum or not pain time duration taking out you can ask your technician time देख लो मैं जब निकलने वाला हूँ 8 minutes था नहीं था and then gradually built on that and so tomorrow when somebody asks you how many have you done you'll say I've done 333. You won't say, I think about 300, maybe 400. That tells you that you're not obviously monitoring. How many times are you reaching cecum? You should know. How many times are you getting into terminal ileum? When you want to, you should know about yourself. These are the targets you're going to take from here. So maintain your book yourself and enjoy it. I have my first book still with me. Sometimes when I'm sitting, it's in my drawer. I take it and I look back and I say, my God, 1991, this is what I was doing. So it's exciting, not maybe today, but when you look back at 20 years later, it's fun. So that's how I recommend. Go back to tell your unit that this is what we have seen in England. It's got nothing to do with Saad Niaz, Saeed Qureshi, Sajda or Sharia. This is to do with what the British system is suggesting. Why don't we apply that to our ward? We have not yet been able to do it, but I can tell you exactly who has reached how many times, maybe by day after tomorrow, latest, because we are recording and archiving every report. Okay? I ask them and they give me the results very quickly. So that's very important, I think. That's one point we wanted to tell you. The other thing we wanted to touch on was there are some newer techniques you might come across if you're keeping yourself updated. Always read endoscopy journals. There are two good ones. One's the European side, one's the American side. They're both good. Your seniors should have them. Now a lot of stuff is available on the net. Read what's happening, learn, be aware of, even if you're not doing it, be aware of what's being done. Dusra, capsule and water immersion colonoscopy. I don't do either of them, but obviously there are reports that suggest that you're for surveillance for polyp. It's the capsule is pretty good. There's a lot of stuff written, but I know this much, and I'll let these two speak. that majority of the people in the world do colonoscopy the way we did it. Majority. Okay, great majority do it the way we do it. And when a new technique comes, obviously if it's established and everybody starts using it, there's no reason why we should not actually start doing it. But at the moment, that's where the world is. If you want to add anything on that?
Capsule, I think, is only useful for looking in between from the jejunum to just proximal to the TI. I think anything else, it's not able to do any therapeutic value whatsoever. It's just for further enhancement and exclusion. So I think capsule does have a limited thing. The issue where capsule is going to become and be more prominent is with regard to diagnostic colonoscopy. Because I think we're going to see a small shift eventually to...
Oh, I'm sorry. I didn't mean capsule. I mean cap. Cap assisted.
Cap assisted.
It was capsule. That's what I was thinking of. Cap assisted.
Cap assisted. Cap assisted is if you anybody drive a car with a trailer.
No, no. I can answer for that. No.
If you drive a car with a trailer, you have to step right out and turn right back in. If you're driving with a cap on the end of your stroke, you have to drive right out and you have to turn back in. It's a completely different technique. Cap helps you with regards to doing your therapies, and it helps with regards just stabilising the tip of the scope. And withdrawing with the scope with the endo cap, which is the one with the little front, that's a gimmick. I can show you video clips and all sorts of things. It does work, but it causes more pain, more discomfort. You can't retrovert, and yes, you can get into the terminal island with it. But the endo cap itself, in use with regards to polypectomy, helps. But the endo cuff, where it's got the fronds coming out the side, is a gimmick. Its flame is about 1 in 20, and it's not worth the money. To add £20 per colonoscopy, because that's the price of the endo cuff, it's not worth it.
I've got loads of. I've got loads of them. You gave them, and they're still lying. I've never used one.
I'll just make a few comments about capsule and cap and underwater. Underwater colonoscopy, I do it on a fairly reasonably regular basis. It is very useful, especially in difficult cases where there is extensive diverticular disease and tight sort of angulation in the sigmoid colon. Because when you flood the colon with water, it basically weighs down the colon folds and there is literally blood through it. A lot of our colleagues are doing underwater polypectomies as well. I don't see much merit in that, but it's something which is done by it. But in special cases, underwater colonoscopy is useful. You use water, clear water, as a medium for visualizing. Instead of air, you use water for insufflating and visualizing it. Regarding the role of capsule endoscopy, yes, Paul is right. The only thing is, for the small bowel, when you are investigating obscure GI blood loss, you do not have any other alternative. Well, you did not have any other alternative apart from small bowel enema or barium follow-through. Now, with that, the catch rate for a lesion as a cause for iron deficiency anemia is less than 20% for barium studies. With wireless capsule enteroscopy, it goes up to 70%. But still, it is only a diagnostic tool, and sometimes it overdiagnoses conditions which do not require treatment or which are irrelevant, but necessitate other investigation. Endocuff, again, is, I found it pretty useless. We've tried it out in our unit. I don't use it anymore. Endocuff has got a certain limited indication in difficult flat polyp EMR. Some people swear by it. I don't personally like it much unless there's a very specific endocap for the EMR. It is only useful in certain targeted lesions, especially in the when the lesion is small. You want to take the whole of it in your scope. The limitations with that are that you should not try it in duodenal lesion because duodenal mucosa is thin and the whole of it gets sucked into your cap or cup, and you might snare off the whole thickness of the duodenal wall. So do not do procedures which you have not been taught.
We would stick to just diagnostic, and to be honest, what you've heard is that there are a couple of other options, but what we have shown to you today is by far you really don't need to do anything because we've done for the last 3 days, and this time we've done over 30 colonoscopies. Okay.
There's just one thing to add. The one thing I'd like to add is that underwater colonoscopy, polypectomy, endocuff, endocap, all of those, they all sound recent new in the last 5 years or so. We were doing them 25, 30 years ago. We were adapting things 25, 30 years ago before we put the cups on the end. We were doing all the same things 25, 30 years. They seem to come full cycle. And now we're back doing it. I do like underwater where you actually use a lot of water in the colon and a lot of spasm. What I don't like is the after effect, because a lot of water in the colon often can leave a patient very stressed. Because water in the colon has to come out.
मैं थैंक यू करूँगा तो मैं उसके लिए
So you've got to balance it. Why are you using it and a distressed patient? Just be mindful, if you are going to use water in the colon, it has to be warm. It has to be warm enough, like if you're going to put a baby in a bath, so 30 degrees or not less than 30 degrees, not greater than 35. Stop spasm, it will actually help relax the bowel, and it's nearly as good as giving someone busting. But the amount you put in can actually embarrass some patients, so you have to be mindful what you're doing.
Okay, so as long as you're aware of this, especially because some of you are going to go for exams, and in CPSP exams quite often the examiners come up with these kind of things. So at least you should know that there you can put a transparent cap, which is what cap colonoscopy is. Like he said, it is, some people use it especially for EMR and resection. And then you have water immersion. So you should be aware of it. We want you to be aware of it. I have no experience personally. We have the report first?
Report.
Yeah, first report. So now you've done a colonoscopy, and if you don't send a proper report to whoever has sent you the patient or for yourself, you get into problems. So this is just an example. This is how we do it. So you have the patient's details, etc. You have the midazolam there. The dose should come there of what sedation you've used. If it's general anesthesia, then obviously you put GA or propofol. What was the indication of colonoscopy? We discussed. I mean, you're all senior guys. You know why you do colonoscopy. One of the indications that I see a lot of patients having colonoscopy is for lower abdominal pain. And lower abdominal pain, in my opinion, colonoscopy just for pain is really a waste of time. The yield is almost zero. But with the associated bowel disturbances, blood, etc., you can do, and you're all very aware of it. So you obviously, it's important to know why you're doing it. So then you come down, and it's very important to see what the bowel prep was like. For the next person to see if the bowel prep was not good and you've still reached the cecum, it is possible you might have missed something small. Somebody is presenting with iron deficiency anemia, they may have a small vascular lesion, you might have missed it because you didn't have a good bowel prep. If you put that in your note, even when the patient comes back to you, you will want to go back and look at it. Okay? If you don't put it, you'll just forget it. And then the patient will go to the next person who will say, okay, colonoscopy is done, it must be something in the small bowel or elsewhere. Okay? So it's important that bowel prep is good, fair, whatever systems you want to use. I usually use fair, good. Good meaning that I've seen everything. Yes, Paul?
In the UK, because you're liable to be sued, I always write adequate.
Adequate.
And I never write excellent.
I never write excellent. That's why you see I did not use. I use adequate is fine. I mean, it was good. And then the next thing what I do in my reporting, and you can, I mean, it's just my personal thing, is I would write good views to terminal ileum or good views to cecum, which means for me and for someone else to know that I've seen it properly. Otherwise, it will say good views on most of the left side, partial views on the right side due to bowel prep. Okay, which is giving you a message that if you are not sure, repeat. So findings, you just whatever you saw. We saw polyp, we saw tumor, we saw strictures, we saw ulcers. Whatever you've seen, describe them. Describe where they are. Describe what you see, where you see it. Okay, in this report we discussed yesterday, for the surgeons it's very important to know how far you are from the anorectal margin in terms of tumor, so that they can decide what surgery they are going to do. Okay, so that's where centimeters are acceptable. That's the only place where centimeters are important and acceptable. We take biopsies. We discussed a little bit during your discussions and teaching. We all have our own systems. I don't take less than 4 biopsies. Okay, now that's me. Doesn't have to. I know people take 2 biopsies, people take 3 biopsies. I take 4 if I'm not sure. I'm not getting good bites, then I'll probably go up to 8. Okay, so this is just an arbitrary thing. I mean, you can pick up, but that's what my practice always has been. I take 4 biopsies, especially when you're dealing with tumor. What site you took it from, conclusion, endoscopist, and obviously important, in our system the pictures will go here and then we have the next page. So nowadays, like Paul was saying, it's important if you reach cecum, you take a picture and show us the appendicular orifice, ileocecal valve. Been to the terminal ileum, take a picture of terminal ileum. So there's no question that you've reached. Okay, the case that I discussed with you yesterday will never happen if you do this. Okay, and there are very few nevers in medicine. This definitely is a never. Okay, so this is just a reporting system, courtesy Shahryar. This is all done, designed, used, not only here now, but also used in like I think 6 other, maybe 6 or maybe even more centers. This is the whatever reporting system, endoscopy reporting system, which obviously we thought was too much for us to spend money on, and thanks to Shahryar, he has actually created this, and it works very well for us. And we have this from 2006. So all cases that we have done from 2006, you can actually take out. All reports are there. That program is very good in probably taking out some data, better than ours, but because we have all the reports, we can do it. It's a little bit more time consuming, but obviously much more cost effective. For us, it's actually free. Okay, so that's reporting. Unless there are any questions, we'll move on to the next.
Just over there, Shahryar, with this reporting system, can you use drop-down menus, like when you pull on your site, and then like sigmoid, and then region like diverticular disease, tumor, polyp, whatever. Is that possible to do with that?
You want to do a query?
No. I mean, just for the reporting system, to make it more
So make it easier, get diverticular disease.
But then that way you can even have like
Cut down that. Okay, for this one thing, I mean that way what happens is that you get, you will be able to retrieve data more easily. Say let's say diverticular disease, you will be able to pick up all of them. That's a good point. So biopsy, this is obviously not opening, but we can go on to the biopsy, and automatically this report, relevant information automatically goes onto the biopsy report, and all we have to do is just sign. Okay, and we can add more pictures and everything else. Okay, Paul, you wanted to ask something?
I just wanted to make a point that I know I said it on day 1, which was Wednesday, but on a report, answer the question, say what you've seen, say what you've done, and say what the plan is. 4 points. If it's not on there, make sure it's on there. Answer the question, say what you've seen, say what you've done, and say what the plan is.
Okay, so that's reporting. Now we'll go to the Akram. What we want you to do is learn a little bit about how the scopes are washed. Something that you probably won't, not relevant so much if you were in, Yeah, but it's important for you to know. जहाँ पे आप काम कर रहे हो मे बी वहाँ पे तो ना पड़े, क्योंकि अगर आपके बड़े यूनिट्स हैं वहाँ सब हो रहा है, लेकिन अगर कल आप अपने यूनिट में कोई स्कोप लगाओगे तो कम से कम ये तो चेक करना आता हो आपको टेक्नीशियन के साथ कि साफ कैसे करना है. अकरम, ओवर टू यू.